everyone. Welcome. My name is Katie Jacksheimer Agarwal, and I am the Vice President of the Client Implementations team at Cedar. I have the honor of facilitating today's discussion with two impressive women in healthcare who I will introduce momentarily. First, I want to acknowledge our audience and thank you so much for an impressive turnout. I'm thrilled to see such high attendance. Today's audience includes those in healthcare technology and innovation, Cedar employees and friends, and Cedar clients. Before we dive into today's event, I wanted to share a bit about how this event will be structured. We'll be taking questions from the audience today, and we really do want to hear from you. So please chime in with the Hop In Stage chat thread. That way, the panelists and I can fold these questions into today's discussion, and the event will conclude in approximately 1 hour. Now, it's my pleasure to introduce our esteemed lineup of leaders, two remarkable women who will be discussing leading the post-COVID digital transformation. Elizabeth Pearlman is a Vice President and Chief Information Officer at HSS, the Hospital for Special Surgery in New York. She has significant experience leading information technology initiatives in hospitals and health departments. In her role, she is responsible for software applications, optimization programs, and solution delivery. And she led an enterprise-wide implementation of Epic, spanning all inpatient, outpatient, revenue cycle, and clinical departments. She is also focused on building HSS's digital infrastructure to support a strategic focus on patient and consumer engagement. Welcome, Elizabeth.
Thank you, Katie. Glad to be here.
And Lisa Stump is Senior Vice President and Chief Information Officer at Yale New Haven Health System and Yale School of Medicine. She graduated from the University of Connecticut School of Pharmacy and the Ohio State University College of Pharmacy with a master's degree in pharmacy administration. Lisa is an active lecturer, commentator, and speaker on healthcare IT and digital health. She is also an adjunct professor and a member of the Board of Visitors of the College of Health Professionals at Sacred Heart University. And welcome, Lisa. We're thrilled to have you.
Thanks. Happy to be here.
Great. So I have a few different topics that I would love to cover with you both. I would love to first start with your career path and leadership journeys. And so to start, I was hoping that you could both tell me a little bit about what your career paths look like, specifically about your backgrounds and what drew you to your current positions. So Lisa, would you like to start?
Sure. Probably an atypical pathway into the healthcare IT space. As you can tell from my bio, started my career as a pharmacist, worked as a clinical pharmacist in Columbus, Ohio, before moving to my career at Yale. And, I would say if you looked at my pathway, you would say I was building my career to become a CIO, but it certainly was never the plan. I often still sit here and say, how did I get here? But found myself as a pharmacist and eventually a director of pharmacy, often looking to technology to help make the work of our clinicians safer, more efficient, more effective, more reliable. And so was often probably that annoying knock on the IT, leadership's door about the technology that I wanted. And often sometimes that frustrated customer of not seeing the technology deliver what I thought it could and should. And so as, our organization continued to build upon a long history, Yale New Haven was one of the first organizations in the country to implement computerized physician order entry. We were always adding technology to the mix. And so I learned a whole lot about how to do that, how to do it well, how it sometimes doesn't go well. And as our organization was then embarking upon major construction projects, we looked to open our new hospital in a paperless format. And it was at that point that I transitioned my career formally out of pharmacy into the clinical informatics realm. And then when our organization chose to implement Epic, similar to Liz, I led the institution-wide project to implement Epic across all of our hospitals and ambulatory sites. What drew me here is that passion and belief that technology can make care better, safer, and drive better outcomes for all of the patients that we're privileged to serve.
Thank you so much for sharing. I love that you noticed the challenge and then took it into your own hands to be able to address it. And Elizabeth, would love to hear a bit about your career journey as well.
Yes, I have a very different career path, but like Lisa, I had no idea I would end up sort of on the technology side and in an associate CIO position. I've always worked in healthcare. Initially, I worked more on the health advocacy side, so political organizing, field organizing. I ran community clinics. I did public health research. Really interested in promoting access to healthcare for all communities. Over time, I moved more into the consulting side. So I spent many years working with a number of consulting firms, with hospitals, health departments, both state and local. I was at the Centers for Disease Control and Prevention for a while, really working on large initiatives about process reengineering, organizational design. And over time, I found that all of the big transformational initiatives were around technology. And I just sort of evolved my career there. I found that I really enjoyed the work around technology. It's exciting, and it allowed me to do this transformational work that I wanted to do and continue to serve patients and staff. I joined HSS just over 7 years ago. I came in to do like a revenue cycle replacement that as soon as I got here turned into an entire Epic implementation. And it was great. The opportunities here have just expanded. Every time I feel like we're finished with one thing, we start something else. A lot of focus, as you mentioned in my bio, on consumer and patient engagement solutions, on digital technologies. And it's ever changing and growing. And so it's really been a pleasure.
Oh, that's terrific. Thank you so much for sharing. And I love the taste of Manhattan in your background there. You can see that the cars going up and down. Well, great. Maybe Elizabeth, I'll start with you this time. Could you maybe tell us a little bit about how your particular role functions within HSS and how you think about approaching leadership in your role as well?
Yeah. So I'm the Associate CIO. In that capacity, I'm responsible for all of the software in the hospital. So all of the applications. And so I have counterparts that I work with very closely, both our Chief Technology Officer as well as my operational counterparts in our digital teams that are not in IT. We place a tremendous amount of focus on shared leadership here. And so we really take that to heart. And I'm, proud of the relationships we've built. And I think that's one of the things that makes us so successful. When I think about leadership, sort of back in business school, they tell you there's like this type of leader and that type of leader, and you're going to be consultative or you're going to be authoritarian. I think of myself as an adaptive leader in the sense that it is really about the situation that I'm in right now and who I'm interacting with. And so it's, which is much more intense than being a single type of leader. It's about observing and listening and facilitating and anticipating what is going to happen, both from those that are around you, as well as where you are on that project. So if you're early, you're ideating, you're consulting, when you're starting the project, you're much more directing than you're empowering. And then you get to a point where it depends how the project is going, what your approach is going to be. So, I hope that my team would agree on that adaptive style, but I think it's very much day-to-day what's needed in that time.
That makes sense. And have you noticed that it's shifted over time, over your career at HSS?
Certainly over my career. I think learning to enable and empower teams is one of the hardest things, sort of, you go through that early manager and up. And it's one of the greatest things that we can teach our upcoming leaders is how to back off and, how to sort of skim the surface and then you go down at certain times and to know when it's important, when people need you and when they don't. And then you go back up and you focus on something else. So it's just a great thing to work with upcoming managers on that skill.
Terrific. Well, we'll come back to the mentorship role. But Elizabeth, I would love to get your thoughts as well. If you wouldn't mind telling us a little bit more about how your role functions and also how you think about leadership and your role within the broader organization.
Sure. So as the Chief Information Officer, I support all of the technology. Actually, clinical engineering reports into me as well. So all of the biomedical equipment and the biomedical engineers and our telehealth department and programs all report into me as well. Within IT, it's a broad array, and you heard Liz mention some of those. So it's the core technology teams, the infrastructure and operations of IT, the Chief Information Security Officer, and that very important role in the world we live in today around ensuring the security of our data and systems, all of the application teams, all of the clinical and business systems that we support. And then we have a very robust joint data and analytics team that are responsible for supporting the enterprise in using all of the data and creating the dashboards and analytics tools. Within the organization, I report into the president of our health system, and so am part of what we call the executive council and cabinet of our health system. And I think, over time, I've been proud of our ability to, and I think I've helped to advance and position the role of the CIO from what used to report into our finance division, I think in a very traditional way, supporting all of the revenue cycle and business functions. It eventually moved into reporting to the chief operating officer of the health system, which I took as also a very positive indicator that we were viewed as much more integral then to the day-to-day clinical operations of the organization. And then in just the last, it was actually probably right before COVID, as the organization restructured, elevated the role of the CIO to that, executive level, reporting into the president. And I think it speaks to, again, the importance that the technology plays in that digital space, meeting the consumer needs, the critically important role it plays in supporting our clinicians. Clinician burnout is a very real and important phenomenon, and I spend a lot of my time focused around reducing that negative impact and trying to continue to elevate, I think, all the power and potential that the technology brings. In terms of leadership, I share a lot of what Liz said. I think we're kindred spirits. The leadership style, to me, is a lot driven by the needs of the day. I think generally speaking, take a variety of those, leadership assessment and profiles. I'm that courageous sort of admiral, kind of role. I like to lead change. I take very seriously the importance of setting a vision that inspires others, and then clearing the barriers for everyone to achieve that vision. But day to day, it absolutely requires that sometimes I'm down in the weeds, and sometimes you need to be up at that 40,000 foot view to make sure that vision is clear. Would love to spend some time mentoring and supporting other leaders and women leaders coming forward, and women in technology are two of the areas of passion that I have as a leader as well.
Thank you. Well, it's clear from both of your responses how visionary a leader you are within your organization. And you both touched on mentorship a little bit. I would love to hear a little bit more about that, particularly working in information technology, which tends to be predominantly male. Healthcare leadership in general tends to be predominantly male. And so would love to hear how you specifically think about mentorship and also bringing women along into senior positions at your organizations. And maybe, Lisa, I'll start with you on this one.
Yeah, I do think this is a critically important topic. Looking back, I can remember very often other women pointing out to me and sometimes thanking me for representing women and being the only woman on the stage or in the room or in the conversation. And I would step back and think, was I the only woman, in the room? Because I never really paid attention to it. I always looked to show up as my full self, which I always, strived to be a very competent and, capable leader and subject matter expert in whatever area I was responsible for. But the more people started pointing it out, the more I started to step back and take notice. I think I'm very fortunate to have had the opportunity to grow my career at the Yale New Haven Health System. We've had very strong leaders. The CEO of our health system for many years now is a very strong leader herself. We have a very strong lean in program, so modeled after Sheryl Sandberg's book and the structures around that. I've had the opportunity to be a leader in establishing that in our organization. seen that grow over a number of years now. Just launching with a very talented young female engineer on my team. We are launching a Women in Technology affinity group to give our women leaders in IT some of that same support. And really now just starting to dive deeply into the concept of sponsorship in addition to mentorship as a very important component. And, I think of sponsorship as that much more active process of, working with and creating opportunities for particular women leaders to advance. And, I could go on for a long time about this. I'm part of a national group called the Equity Collaborative that also seeks to advance women as leaders in healthcare. And I've had the opportunity to help advance that from a national level as well. Critically important.
Yeah, thank you so much for sharing. And I love the addition of sponsorship to the question as well. And Elizabeth, would love to hear your thoughts on this as well.
Yeah, it's an interesting question because I think conceptually, I know this is true, that IT is predominantly, the healthcare industry is predominantly male and IT is predominantly male, but my experience has been a lot of women supervisors and role models, and I feel very fortunate. Certainly in consulting, I had a couple of women supervisors, and I think that's part of why I made the transition, being able to see women in those roles. I'm fortunate here. My boss, our CIO, Jamie Nelson, is amazing, another amazing woman. And I feel like the opportunities are endless. We have administrative and clinical leadership that are women as well. I think when I look at the team that I have, it's very well balanced. It's something that we look at all the time. What's interesting to me is that, I meet with everybody as they come in, and with a lot of the guys that I meet with, the men who come in and I talk to them about what their careers and what they want to do, I often get that I want to be a CIO. With the women, I don't get that very often. It's very rare that a woman marches into my office and says, yes, I'm an analyst 1 or an analyst 2, but I'm going to be a CIO. And so I think having women in these roles is just so important to be able to see that, hey, I could do this, maybe I want to, maybe this is something I can grow into, and showing people what that means. And I think it's also about having very clear career paths, really empowering people to grow over time so they can see that it's within their reach is so important. And I agree on the mentoring side too. I think there's all different ways that people chart in their career. So some are more formal, they want their career paths. Other people need that mentor to really assign them. Some people want something that's external. Some of the groups maybe that Lisa discussed. So I think having all of those possibilities is really important just to the variety of women that we have. We also take part in an intern program where we bring women in technology from the local colleges every year. They do an internship with us. Many of them have stayed on. And it's really just amazing to see the talent that's out there.
That's great.
Oh, that's wonderful. Well, thank you for sharing, and very much agree in the power of representation. So both of your organizations are very fortunate, I'm sure, to have you both in your roles as well. I would love to shift gears a little bit to talk a little bit about digital transformation during COVID, and then we'll get to the beyond portion of this as well. But you've both managed your teams through a really unprecedented crisis during this past year plus. And so I would love to hear a little bit more about some of the technologies that you had to implement really quickly out of necessity. And what have been some of your reflections on that? What's here to stay? What was here more temporarily? Maybe I'll start with Elizabeth if you want to kick this one off.
Sure. So there is a whole set of technologies that we use for a short period of time. And we didn't really talk about sort of our organizations, but HSS is a specialty hospital, musculoskeletal specialty hospital here in New York. And we do primarily orthopedic surgery in-house. So when COVID started, it's not typically what we do. We had to convert our ORs into care units. We had to put things on the floors. We had to put technology so that we could monitor patients, so that we could participate and do what we needed to do in the city. And that was just an amazing, amazing transformation. That being said, of course, now we've gone back to our regular services. So when I think about what's really here to stay, of course, I'm sure we're going to talk a lot about telehealth. We're going to talk a lot about remote work, are some of the biggest ones. And I think my thoughts on those two in particular and why they were so successful. We were able to get thousands of people home overnight. We were able to ramp up telehealth very, very quickly to make it our just accessible to all of our patients, was because one, we had the technology already, which was great. We just hadn't had the uptake on them. And then two, we were focused. That's something that we've always worked towards. So how do we do a few things really well for a short period of time? And I think COVID allowed that. And the other thing was that our users were okay with 80% for that time. So, we all say we're good with that MVP, but when it comes down to we want to go live, it's not quite exactly what they want. So, but it was okay during this time. It wasn't easy. I got to take a tablet home with me and use it as a soft phone, or a patient, can't download Zoom. But our operational users were okay with that for that time being. And I'm trying to keep that culture because it allows us to try things and deploy so much faster. I mean, some of the other technologies that have really taken hold, a lot of the remote consults and rounding on the floors, alarms, video and audio from monitoring of patients. We had some things that, didn't really land. We tried to do geofencing for check-in and stuff, but it's missing certain components. So I think we've gotten to try a lot of things. I think most of those that I've just mentioned are here to stay, though. They're just going to get better. VDI is just going to get better. Telehealth is just getting better. So I feel really fortunate that we were able to roll those technologies out.
That's great. Lisa, I would love to hear your experience at the start of the pandemic as well.
Yeah, very similar. And so I don't want to repeat a lot of what Liz said, but, clearly, so we are, I think, the opposite of a specialty hospital. So our 7 hospitals range from small community hospitals to the large, academic quaternary care hospital in New Haven, and a large ambulatory footprint as well. So telehealth absolutely was probably, I think I was one of the lone voices advocating telehealth in our health system for years. And then, thankfully we had the right building blocks in place and we were able to scale that dramatically. Remote work was certainly a big piece of that. To add to, what Liz talked about, I think the other thing that the pandemic really exemplified was the importance of data and real-time data, right? We were tracking the spread of the virus, the movement of our patients, the transition of, the operating rooms or post-acute care units into, ICUs and back and forth. The ability to analyze the data, create meaningful dashboards, and push them out immediately, was something that I think is also here to stay. We've now, I'm always heartened when meetings now, instead of people bringing up that static PowerPoint slide of the graph that shows what happened last month, they're pulling up the live dashboard and it's the data that refreshed 2 minutes ago. And so I think that was a really positive outcome of the pandemic. I think the other piece is a lot more use of that real-time, texting, the use of chatbots. So one of the early things we found, our health system, our doctors' offices were getting flooded with questions. People didn't know, what are the symptoms? Am I sick? Am I not sick? Do I need to get tested? Where do I get tested? How do I get tested? And we were writing that playbook, as it was happening. And so we stood up a large call center that was, Ask YNHH, Ask Yale New Haven Health. We built the call center within the first couple of weeks. Being close to New York, which was one of the epicenters of the pandemic, we were seeing patients very early in the overall flow. And we built the command center in a kind of small space. And our clinicians, we weren't social distancing then. That word hadn't even sort of come into play. Very quickly, we realized for the protection of our teams, we needed to pack that up and move it. And so we moved it into a much larger space. And then about a week after that, we sent everybody home. And so the ability to do all of that remotely, really came into the forefront. But supporting that, it's one of the things we've also recognized in a big complex health system like ours. giving people that one phone number to call with whatever question they had is something that we've now made a permanent part of the process. And some of those patients ended up getting referred and handed off immediately for a telehealth visit, that they were, in need of a physician to assess them. And those types of trends, that easier access and navigation, is something that's, I think, really taken hold. And then, as Liz said, a lot of the tools that were already available that we just didn't have great adoption of, automating all of the pre-visit intake, the pre-visit questionnaires, and gathering of information from patients, e-check-in, trying to really eliminate time in the waiting room is something that also took hold.
Oh, that's great. Well, you both have touched on so many topics that I want to address in a little bit more depth going forward. So thank you for that. Lisa, I also appreciate, my husband and I were just talking last night about when was it where we first wore masks? And, it's hard to think back in those very early days how, we didn't know, right, about masks or social distancing too. So thank you for sharing. I would love to maybe touch more deeply on telehealth to start. And you both mentioned this in your responses. Can you talk a little bit about, from the clinical side, how remote patient engagement you think will continue to be an aspect of your organizations? Do you see telehealth rates continuing to stay high? Have they rolled back at all? How will this meet in the fabric of how you provide clinical care?
Yeah,
go ahead, Lisa. Go ahead. You can start.
I think we set a goal coming out of the pandemic that a third of our telehealth visits would be, a third of our ambulatory visits would be delivered via telehealth. I think what we're seeing nationally, about 14 or 15% of all medical claims right now are related to telehealth. And we're right about there. I think, so to your point, we saw that quick and dramatic increase. It did scale back a little bit. I tend to believe that we're going to see that almost sine wave cycling. Many clinicians and patients, I can see you today via video visit because I need to essentially do some reconnaissance. I need to get some information. I need to ask you some questions. You might be able to get me some vital sign information if you have devices at home. But for your next visit, I need to see you in the office to do a more, in-depth physical exam. And so I think we see that fluctuation over time. And even the statistics I mentioned are big averages. In some of our specialty areas, behavioral health, 90% or more of their visits are being done via telehealth today. Believe it or not, our GI services are in the high 80%, of doing their visits via video. And so it also matters, I think, the type of specialty that we're seeing. But the projections are strong. We've surveyed our own patients, and those data are out there nationally as well. It is a huge patient satisfier to not have to get in your car, leave home or your office, navigate parking garages and complex buildings. People would much rather have that happen from the comfort of their home. And we have our clinicians telling us they find the visit of greater quality. Very often the patient will, grab a family member who's nearby to come and offer information or help listen. And so I think telehealth is clearly here to stay.
Yeah, I agree. Agree. For every reason that we all love to do things remote, that to the ease, it's definitely here to stay. We've also seen the drop off that Lisa mentioned, but certainly still much, much higher than anything we could have imagined before the pandemic. When I think about how it grows or changes, it gives more opportunity to people who may be farther away. So that's how I think about in terms of telehealth. It's more patients and for new services. I think the question becomes, how do we grow telehealth so that we can perform more services with you while you're still virtual? And so if it's a certain types of visits will be okay virtually now, but others you have to come in, how do we change that? How do we make it more interactive? What other tools do we offer so we can do more measurement, either of device data or other things, so that we continue to grow? And it's really just about choice. Offering choice is always good because it means more patients are going to come in, they're going to get better care, and their outcomes are going to be better if it's at their, if it's how they want their services. So definitely still growing, and I have lots of ambition for it. So
yeah, And if I could just add, I think it's also, we often hear from our physicians, it is a satisfier for them. So I mentioned the burnout of technology sometimes, but the ability of the physician to care for their patients, or that on the weekend, emergency kind of call that they need to see the patient, we're hearing a great deal of satisfaction from our physicians as well.
Oh, thanks for sharing. Lisa, you mentioned in your earlier response the idea of the command center, and a question for both of you. I would love to hear a little bit more about your experience with more of a centralized command center as they've been gaining tractions in healthcare. And just for our audience who may not be familiar with the term, these centers often integrate data from various sites to help enable real-time analytics and decision-making. And so maybe they have a different term within your organizations, but at the core, I would really love to understand how you both have thought about incorporating real-time data and analysis into your decision-making, both clinical and more administrative.
Sure. And I little joke, because words matter. We started out calling it a command center, and I still slip into that language, but folks found that too military-like. So it's now our capacity coordination center, is what we call it. But yes, it was probably a year or two before the pandemic broke that we stood up our capacity coordination center, leveraging the real-time data, again, most of it coming from our EMR platform. We centralized key services throughout the hospital who, up until that point, had all functioned fairly independently. Everybody had a dashboard or a data tool, but it was theirs, and they looked at it independently and made a decision. And then there was a lot of that other department didn't transport the patient, and that department didn't get the bed clean, and the nurse might not have done what they needed to do. We spent a lot of time, I believe firmly in it's about people, process, and technology. And so we certainly invested in the technology and the data and analytics, the real-time data being a key component, but getting the people all together in one room, seeing that right data and information together at the right time, and organizing them around the response to the information was really key. We're continuing to build upon that. We're layering in, some artificial intelligence and predictive tools as well. Again, we went from understanding what happened yesterday to understanding what's going on right now, and we're trying to turn that into what's going to happen later today and tomorrow and next week. That is another function that I think without it, managing through the pandemic, I can't even imagine how we would have managed the throughput and the stress on beds, and the need to co-locate various patient groups would have been, like I said, I can't even imagine how we would have managed it. So really critical. I think we moved from really focusing on the inpatient units, and then extended the same thinking into our ambulatory environments as well. So ensuring that we are maximizing the throughput now as the volumes returned into our ambulatory settings. We want to maximize the throughput there as well.
What an undertaking. Elizabeth, would love to hear your experience as well.
It's a very impressive story, Lisa. We've been courting with the idea of a command center for a long time. We fortunately have a lot of peers who've invited us to visit, and so we've seen command centers more of that traditional model where you're watching the helicopters come in and you're looking at your ED capacity and you're looking at what's available up on the floors. Not so pertinent to what we do, but just fascinating. We've looked at here in New York, these more the OR command centers, sort of techs watching what's going on in the ORs. We went to another site, which was really observing the critical care units. I mean, there's so many possibilities here in different ways that people describe command centers. I think, like Lisa, our idea of it has evolved over time. It is really about having the data to make joint decision making around throughput and operations. And so what we learned during COVID, our analytics team is amazing, that really just making that data available at real time so that we could make decisions that's the command center, right? And everybody now is remote, so we don't have this large mass of people that are looking at things together. In some cases we do, but really looking at certainly during COVID was about just all of the operations of managing COVID and consolidating offices and, wait times and things like that. And now certainly around OR and throughput, it's really about people having the dashboards they need to, when they get there, to make those decisions together as a group. So we're thinking about it a little bit differently, but certainly creating those dashboards and the analytics that are helping us make those decisions real time.
That makes sense. It feels like real-time data and analysis being at the core of both of your strategies. Elizabeth, I would love to start with you for this one. Earlier this week when we had the chance to talk, we were talking a little bit about personalization. And CDER's 2020 Healthcare Consumer Experience Study found that 68% of patients said it was important to customize their experience with their healthcare provider. And so I'd love to understand first how you think about defining personalization. And then secondly, how do you work with your team with cutting edge systems and tools to enable that personalization?
Yeah. So I think personalization is a continuum, right? And in the sense that we're really good in healthcare at making care specific to you as the patient. You call us, we ask you a number of questions, we see what services you've had, or you go online and use our open scheduling, and it helps triage. We get you to the right provider, and that's particularly important to us because they're highly specialized, right? You get to that provider, and you're getting questionnaires that are specific to your condition. We're identifying if you're at risk, and that's in turn determining your care. You're getting the right patient-reported outcomes. All of that is specialized to you and what the services you're having or who you are, but it's not really personalized in the sense that you didn't define it, right? It's about the consumer saying, this is how I like to be contacted. This is what motivates me to do my rehab. This is how I like to interact with my provider. And so I think we're getting there a little bit in the sense that certainly around messaging and communications, we have a lot more capability for patients to decide. We have more options around education. Digital health just by nature gives people more options. I think we are moving to a place where we as the provider know enough about you to help then drive that care. So, a little bit of that. We think it's so easy. Netflix does this. That was an example we talked about the other day. They anticipate what you're going to watch. It's not so easy in healthcare, right? There's a lot of different factors here. So I think when I think of sort of that 12 months, if we could get to the personalization that it's really patient driven, we can add in some things that are suggested. They're not really watching their videos. Maybe we change our communication style with them. But that's how I think of personalization. I think of it as a journey. We're good on the left. We have more work we can do in the middle, and I'm looking forward to moving over to the right.
Thank you so much. Lisa, would love to hear how you think about personalization on your end as well.
Yeah, very similar. I think I start with, I spend a lot of time talking with my colleagues in the health system to shift our thinking from patients to people, because none of us wants to be a patient. Right? We all are working very hard probably to avoid being a patient. And most of us as people are working hard to maintain our health. And to me, that the personalization of care is about meeting people where they are on that journey and helping them manage their health in a way that's meaningful for them. And in the full context, again, big health systems like mine, I have service line leaders, right? So I have folks who do nothing but think about cardiology care, and I have people that think about urology care and cancer care, and very few people interact with one service line, right? I'm a whole person who has some cardiac issues, and I might have, trying to prevent cancer, but meeting people where they are, understanding what their goals are, and then to Liz's point, it's about choice. From I might not want to take the medication that you prescribe, even though it will make my blood glucose better, because the side effects are just not something I want to put up with. And I'm willing to have some other, level or method of care. And it's simple choices. As Liz said, do I want to be contacted via text, via phone? I'm the kind of person, I prefer not to talk to a human to do those simple transactions. I want to do it with 2 thumbs on my phone and be done. And so understanding the preferences of the individual person to me is what personalized care and partnership is all about.
Great. Well, thank you both. And I would love to switch gears a little bit here. And of course, we're talking through a CEDAR channel here. And of course, we care deeply about the medical billing experience. And so we'd love to get your thoughts on this. And, we know that 84% of people were anxious about covering their healthcare costs when we surveyed our audience last year. And so would love to understand how you both are using technology to make the healthcare billing experience easier and more compassionate for the patients that you serve. And so maybe, Lisa, I'll start with you this time.
Yeah, I'm very fortunate. My colleagues that manage the revenue cycle have taken very seriously what we call the patient financial experience, and that the interaction that our patients have with us sort of starts with the revenue cycle and the financial experience and ends with it. And so, we very much, building on what we talked about in terms of personalized care, it starts with transparency. People need to understand what their care will cost, what that cost includes, and then we need to give them options that meet their needs to help meet their financial obligation. And along the way, all of the choices that we talked about. Do they have an easy way to see an estimate of their upcoming services, to see their bill digitally or on paper if that's what they choose, to get the level of detail they need, to get information about their balance as they're moving through their payment plan. So supporting them digitally and with a caring team who understands the financial circumstance has been our approach.
Great, thank you.
Yeah, I think my response would be fairly similar. A few years ago, I can remember when I was in consulting, we used to make out little cards. If this person has this insurance, this is what they're going to have to pay, and you were updating them. But we have so much better information now. A few years ago, we made estimates available to the financial staff so they could meet with consumers and with patients and have those compassionate conversations. Like everybody else, I'm sure on this call, we went live with transparency this year so people can go onto the website. What is something going to cost? We have it tied to quality data so you can see, oh, I need this service. This is more about HSS and their quality information. But it's a limited set of services so far that's required, and it's growing, but we still have work to do. As an industry, we still have work to do. No one ever looked at an EOB and said, oh, I get that. This is exactly what I'm going to pay and why I'm going to pay that. And it has just all the complexities that a hospital is a whole ecosystem of different providers. You're not paying one utility bill here. You have many different providers that have different backgrounds and come from different facilities. You have your ancillary. And so trying to figure out a way to communicate that, because I agree on the transparency. And people just want to know, what's my insurance going to pay? What am I going to pay? They should know that nobody should go in for a service and not know what it's going to cost them. It's really unacceptable. And we need to do better as an industry.
Yeah, agreed. It's one of the few areas where you have a very large purchase and really no insight into what it will end up costing you at the end of the day. Would love to get your thoughts on another big area, which is AI in healthcare. And so, as we know, the ability to turn data into fast and meaningful insights has been very much a game changer, which has empowered physicians throughout the diagnostic journey and helps to guide the right treatment decisions at the right time. But it also may have its potential pitfalls too of relying overly on AI. And so I would love to hear from both of you, and maybe Elizabeth, I'll start with you on this one. What do you see as the virtues of AI and the potential pitfalls?
Yeah, so a couple things. I would say in healthcare, we're pretty good at predictive analytics, and that technology has been around for a while, predictions of a limited set of data, but it tells us fall risk, or it tells us sepsis risk, or rates for readmission. And I think even in that realm, we can do better, right? So I'm meeting with my provider. They know a lot about me. It's still a limited set of information, but they can certainly predict what's my chance. If I do this many rehab visits, what's my chance of my outcome is going to be good. And I think there's a lot of space there for us to improve. Then sort of further down the line is the machine learning. And I think It's a lot. It takes much more data, and it's really learning over time. And there's a lot of really interesting places where we're looking at this. Certainly around natural language processing. I mean, that's one of the ones that's been a little bit ahead. How do I take information from providers or even patients and sort through that very quickly and come up with insights? RPA, robotic process automation. How do I take repetitive tasks, do them quickly, automate them, and learn about it as I go? There are a lot of really interesting technologies in this space that we're just starting to work on. Some of the messaging things we've talked about. How do I know, like, you haven't responded to any of my phone calls, so I'm going to start texting you. I think we're starting to chip away there. In terms of the pitfalls, I don't think it's any different than what we had with, decision support or any other help that people have gotten along the way. On the operational side, maybe it doesn't matter. I text you at the wrong time. It wasn't the time you liked. There aren't so many repercussions. But on clinical side, when you get to personalized medicine and other guidance that you're giving clinicians, but they're still weighing in. And I think they're still about the clinical decision making that's so critical.
Thanks for sharing that experience. Elizabeth, or at least I guess I should say, I would love to hear from your end what you also consider some of the benefits and areas to watch out in AI.
Yeah, I think AI can be and we're seeing it, a really important complement and augmentation to the clinician, right? That there's an art and a science to the practice of medicine. And, we're seeing the benefits of AI and helping the clinician hone in on the patient who likely most needs their attention, or back to our revenue cycle conversation, the people in the billing call center to know who's the patient they should call first today, because the AI is helping to inform that decision. There's a lot of worry often that AI is attempting or wants to replace the clinician and the human, and we believe really strongly it is a partnership, and it allows our people to focus on people and those important things, and let the technology help sort out the things that no human should have to spend their time doing, those very redundant and repetitive things. And so I do think we're early in that journey, a lot more to come, but I think that's going to continue to be a key trend as we go forward. Some of the risks, I think that the models are as smart often as the data that feed them, and we see. So when you think about AI and some of the, facial recognition tools, we back to some of our earlier conversation, we know those tools are biased, that they have a difficult time with the female face or people of color. I think are good examples where, as clinicians, we have to be very engaged in understanding how the models are built, the data that were used to build the model, and making sure they're applied in an appropriate way. But I think, again, huge potential that, smart, informed clinicians will help advise and mitigate on the risks.
That makes sense. I mean, to your earlier point, the people and process obviously play a huge part in that, in addition to the technology.
Exactly.
Well, great. Well, as we're nearing the top of the hour here, I wanted to ask one closing question, and then I'll turn over to Q&A from the audience, which I know that everyone's been answering or putting questions in. But I would love to get your thoughts, as we slowly ease past the pandemic here. This era of digital transformation provides a lot of great opportunities for what's ahead. And so I would love to hear from both of you. What are some of your biggest hopes? What's on your wish list for the future of digital healthcare? And Lisa, I'll start with you on this one.
Yeah, I think my hope is simple, that, we continue to leverage technology and the digital transformation to bring the best health to every person. It's a big goal, but I think we have the potential to do that, to meet people where they are and bring them to their healthiest self.
Yeah, I would say, we talked earlier about that personalization really being person-focused. We haven't talked as much about interoperability, but that's sort of even spreading even more. That I, as a person, have care across a number of different places, and I want people to be able to see me in all of my care. I think when I think about people being able to make more choices and driving their own care, it's sort of that trifecta of winning, right? The person is happier, the patient is happier, they're better clinical outcomes, right? Mm-hmm. So the more that I drive my own care and it's meaningful to me, better clinical outcomes, and of course that drives revenue as well. So it's just sort of like a win all around. And I think we can just make great strides with digital solutions, sort of just one step at a time.
Thank you. I know we didn't talk much about interoperability, but for the next conversation, there's too much to cover. So I'll pass over to the questions from our registrants and our participants here today. But one of the questions that we got ahead of time, which I thought is a really interesting one, would love for you both to reflect on, is that there are so many competing priorities as you develop a digital healthcare strategy. If you had an additional 5 hours in your week, where would you dedicate that time? And Elizabeth, would love to maybe start with you on this one.
This is an easy one for me because it's really about planning. I think if you asked any of my peers or the people on my team, I think sometimes we get so excited about different technologies and different projects. It's easy to launch in. There's just a lot of options. It's not a little bit different than 10 years ago when we were looking at EMRs, and there are 3 EMRs, and you go and you plan it, and it's just long term. I think having that time to take a pause and regroup every week, every few weeks as a team, and what is the next priority, and is this getting towards our strategic goals? That's what I would spend it on.
That's so powerful. Lisa, what are your thoughts?
Yeah, I think I would spend it in the ideation phase, and really working with our user groups, groups of people, patients, and our clinicians, really better understanding their problems, right? We do all of that planning and implementation, as Liz said, and then we hope people are using it well. We typically hear when it's not working well, but we often don't realize people are using it okay, but they're not using it, to the best that it can be used, or that we just miss the mark a bit in solving the problems. And in our busy lives, that's often the thing I find there's just not enough time to do.
I think it's a really great point. I don't think, again, as an industry, we're great at getting feedback on that experience. We get a lot of feedback on the clinical experience,
right?
But we don't get a lot of feedback on the user experience. We have a panel, we send a survey, but really watching people use technology, you don't have as much opportunity to watch patients using technology.
Right.
You could round with the clinicians. So I think that's a really good point. Like, how do we engage people more to help define our future?
That's great. Well, I'm going to ask a couple of questions on behalf of our audience today. And just as a reminder, if anyone else has questions that you want to put in, feel free to add those to the chat. But I'll start with, have your organizations adopted any best practices or techniques from other industries outside of healthcare?
Let's think about that. I'd probably actually point to the remote work. Healthcare, I think, was very slow to that space, very much accelerated by the pandemic, and, a very clear tendency at first to revert back to bringing everyone, on site. And I think, we are watching other industries, resolve that question. And I think rethinking our own strategy around it and keeping more in the remote work is good and productive, and probably the right thing to do for many aspects of our workforce. That was a tough one. That's probably the easiest one I could think of.
Oh, that's great. Elizabeth, does anything come to mind for you?
For me, it is actually our focus on digital. I think when we started this journey, we really tried to look outside of industry. And as we bring people in, as we bring partners in, we're always looking for people outside of healthcare. What is the best experience that I can have through a contact center, on my phone, and what are some models that we can look to that are not inside healthcare? Because I know in healthcare, we're all early, right? Everybody started with their MyChart app, and it was evolving over time and building sort of point solutions. But what what solutions out there are really delightful and why, and how do we copy that so that we can provide more services and new services through our digital solutions. So I would say that's top.
Yeah. Yeah, I think there's probably, building on what Liz said, I have one colleague of mine in the health system, and again, prior to the pandemic, he and his family would travel to Disney every year, and inevitably he would be texting me from the theme park, Lisa, something great just happened. I got alerted, the ride's ready. I'm like, why can't we do that, for our patients? So we do often, I think, bring those examples in for sure.
I love that. Elizabeth, maybe I'll start with you for this one. I would love to hear how you adapted your organization's technology strategies to facilitate a shift to value-based care, if at all. And if not, what's still in progress?
So value-based care is really about quality and sort of outcomes, and it's being able to see that data. So back to the discussion we had about data. How do I have enough information to be focused on outcomes and quality, in addition to sort of all the throughput measures that we used to use? So I think like this one, I find a little bit tough trying to think through if we've actually implemented new technologies for this model, but I think it's been much more about how do we have the information we need to make the change that we want, and to be able to do the reporting.
Yeah. Yeah, I think for us, it's very much shifting the focus to preventive care, right? We in a value-based model, we need to provide the right care to the right people in the right setting. And very often that's not our big expensive hospitals. And so it is, supporting that shift to remote patient monitoring and telehealth and acute care in the home, the outreach and providing people with those digital tools, right? Whether I'm getting the digital thumbs up that I've done a good job, I got my steps in today and I lost 10 pounds and my blood pressure looks good. Whether it's the digital thumbs up or a human, that reinforcement of the right behavior is a positive thing. And so to me, I think that's, again, probably the biggest silver lining in the value-based shift is helping people manage their health as effectively as they can.
Yeah. Well, as our time here is drawing to a close, I want to thank our audience for listening and asking very thoughtful questions. And most importantly, to you, Lisa and Elizabeth, thank you so much for spending your time with us. I learned a lot. I'm sure our audience did too, and very much enjoyed the conversation. So thank you so much for your thoughtful reflections and sharing your learnings with us.
Thank you for being a great host.
Thank you. See you soon.